Hello there, this is Dr. Mintz. I want to do this focused session on mediastinal anatomy because it's needed, and it's often very difficult for people to get this experience because when radiologists are reading chest CTs, they're usually looking at the aorta or pulmonary artery and its branches, and not so concerned with some of the interrelationships of the chambers. But I think you need to know your way around the chambers of the heart, and so I'm going to try to make that happen right here and right now. Okay, let's just get a little orientation. And we'll go over these things again, but this is the left innominate vein, and this is the right innominate vein. The injection is obviously in the left arm, or possibly in the left subclavian vein. So this is left innominate vein and right innominate vein join, they fuse, they merge to form the SVC, and the SVC courses down, down, right alongside of the aorta here, and it empties into the right atrium. Why would it empty into the right atrium? Well, this is all deoxygenated blood coming back from systemic circulation, so it needs to go into the right atrium and then the right ventricle and then out the pulmonary artery, which is right here, which then divides and goes to both lungs. See that? Goes to both lungs, right and left main pulmonary artery, to be reoxygenated. And then, once the reoxygenation has taken place, let's look. You see that the pulmonary veins come down here, and here's one coming from the right lung, pulmonary vein right next to a pulmonary artery, pulmonary vein coming into the left atrium. And here's a left pulmonary vein right here coming into the left atrium. Okay, and there are usually two big veins that empty on both sides into the left atrium, and then you have the left atrium ready to contract and push blood into the left ventricle and then out the aorta. Okay, so here again, just to see the dynamics of what's happening here, you inject your contrast, and we see various phases of this depending on whether we're doing a regular CT chest or a pulmonary embolism chest CT. So here we have the SVC emptying blood into where now? You should know it, and you should be able to see that this is the right atrium. And the right atrium in turn empties into the right ventricle, which is here, and the right ventricle then sends the main pulmonary outflow tract and subsequently the pulmonary artery, main pulmonary artery, into the superior mediastinum, where it crosses under the aortic arch. So here, if I go up higher, descending aorta, ascending aorta, this is the aortic arch if you go all the way up. Now if you come down, then you land on top of the main pulmonary artery and the right main pulmonary artery. This relationship changes a little bit as you go from top to bottom, and you'll see that here the aorta and pulmonary artery relationship is a little different. The pulmonary artery is at about the 2 o'clock position, let us say, from here. 2 o'clock position, maybe 1 o'clock position here. And then as we go down, you see it goes a little bit more around the aorta. So now it's at about the 4 o'clock position. You see what I mean? Do you see that? So now if I go up, this is the clock, and the hand of the clock, the hour hand, is pointing to the aorta, and so that's at about 2 o'clock. Maybe this is 2 o'clock. Oh, here we go. That's even farther up. So here you have the aorta, or the pulmonary artery, and it's at least 2 o'clock, maybe even 1 o'clock position. And as you go down inferiorly into the pulmonary artery, you see that the pulmonary artery then assumes about a 4 o'clock position. Why does that matter? Because this is where, in development, these two arteries are one artery. And what happens is a septum divides one from the other. And from top to bottom, that septum forms and divides this main fetal artery into a main pulmonary artery and an ascending aorta. And it's at that interface that this barrier, this separation is formed, and it is the reason that this relationship exists. So what you're seeing is a leftover of one big artery here that has a septum that was formed in utero to divide the pulmonary from the systemic circulation arterially, and that's how this gets this appearance. So when you see those structures next to one another, and here you see even in more extreme relationship, this is at about the 1 o'clock position, the pulmonary outflow tract in relation to the aorta. Okay, so you get the idea. I think it's a helpful thing to keep in mind, because then when you see things moving around, when you go up and down and up and down, it makes some logical sense why it's doing that. Okay, so here's the aortic arch. That makes this ascending aorta, descending aorta. And the ascending aorta begins right here at the aortic valve. And the aortic valve, whoops, the aortic valve is a 3-leaflet valve. And one of the amazing things here is that, remember that the heart itself needs that oxygenated blood. So it has to get systemic blood to the myocardium of the heart, just like everywhere else in the body, with the exception of the lungs, of course. So here you have the right coronary artery coming off the aorta, and here you have the left coronary artery coming off the root of the aorta, and both of those are in areas that when the left ventricle contracts, these leaflets flip up and they cover the orifice of the right coronary artery and the orifice of the left coronary artery. So you have to imagine here the valve leaflets look like they're kind of closed, maybe, in the aortic valve. But these leaflets, 2 of them, flip up and actually cover the coronary arteries. Why would that be? Well, that happens because when the heart is contracted, the myocardium is very tight and would be very, very difficult to perfuse. Therefore, the best time to perfuse the myocardium of the heart is in diastole, and it's certainly not in systole. So this beautiful design means that during the heart's vigorous contraction, there's no blood going into the coronary arteries because it wouldn't be able to perfuse the tissue of the heart anyway. And then during diastole, when relaxation occurs, these valve leaflets flip down, and that's when all of the pressure in the aorta, which is backed up by the valve leaflet now being closed, all of that pressure goes into perfusing a lot of arterial areas, including the coronary arteries. That's kind of a mouthful of instruction and description, but it's an important principle about how the heart is designed and the reasons behind it. Okay? And then this would be the left anterior descending artery right there. Okay, what else do we have here? We have the main pulmonary artery, which we've talked about a little bit because it's the aorta's pal. They were once twin siblings, you could say. and the ascending portion, the main pulmonary artery, goes superiorly and then divides immediately inferior to the aortic arch into the right main pulmonary artery and the left main pulmonary artery, which you have to have because you've got two lungs. This is the SVC, plain and simple, riding right alongside of the ascending aorta. This is ascending aorta, this is descending aorta down there. Okay, so the pulmonary arteries go out and they branch through the lungs, and then they come back and they return through the pulmonary veins. Now, is this oxygenated or deoxygenated blood? In the pulmonary veins, it's going to be oxygenated. It just went out through the arteries to the alveoli of the lungs, and now it's oxygenated, and now it's going to come back into what chamber? The left atrium. Good, the left atrium. And the left atrium has pretty much two venous paths that go into each side. So you have two prominent venous entry points on the right and two on the left for pulmonary venous return to come back into the left side of the heart. And then, of course, once it's in the left side of the heart, it goes through the mitral valve into the left ventricle. And this is where we have the mitral valve leaflets that open when the atrium is contracted, and then as soon as the atrium relaxes and the left ventricle contracts, the valve leaflets shut. Whereas the aortic valve is doing the opposite. It is open when the left ventricle is contracting. Now, there's a great deal of force developed in the left ventricle, which is fine because you need it to go through the ascending aorta and into the aortic arch and throughout the body to perfuse the whole body. But that runs into a little trick here because that means you've got these sliver thin little valve leaflets, and the full force of the left ventricular myocardium is pressing against them and doing everything possible to cause them to flip backward into the left atrium, which would be disastrous. And that can happen in some people if they've had a heart attack that affects the protective device or protective mechanism here. But here you have the papillary muscles in the left ventricle, and they are connected by little threads, little chordae tendineae, to the margins of the mitral valve. And so these papillary muscles and string complex, the chordae tendineae are the strings and the papillary muscles are muscles. The muscles contract and thereby equilibrate the amount of shortening necessary to keep these valve leaflets from inverting. So this is a very elegant mechanism wherein the valve leaflets, which are thin and lightweight and able to move with great agility, these are kept from inverting because of these papillary muscles and connected chordae tendineae, which are connected to the margins of the valve. Now, if you had a myocardial infarction and if it affected one of these papillary muscles, that can actually cause it to fall off away from the wall. It could make it thinner, but it can actually traverse the papillary muscle, and then you have a papillary muscle fragment flapping in the breeze and not holding on to its chordae tendineae very well, and that can result in regurgitation. Regurgitation from the blood from the left ventricle into the left atrium, which can be extremely problematic. Okay, everybody with me still? Why is this so dense? Why is this so bright white? Because the patient's blood from the injected arm, the left arm, went into the left subclavian artery, and then the left, subclavian vein, and then into the left innominate vein, and then into the SVC. Okay, so that's the complex of the heart, and so you should learn your way around it, but once you get used to this and see left atrium, left ventricle, right atrium, right ventricle, interventricular septum, interatrial septum, papillary muscles, chordae tendineae, mitral valve, and aortic valve, and right coronary artery, and left coronary artery with the left anterior descending heading off this way, and the left atrium with the pulmonary veins coming into it, you can intuit the mediastinal structures. Okay. Now for something entirely different, but pretty similar. Let's look at this. Okay, so now we have a little different view, don't we? It's the same stuff, same anatomy, nothing changes. So let me window that a little bit. So what's this? The ascending aorta, right. And so the ascending aorta comes up, and let's see, first it gives off this vessel, which would be what? The right brachiocephalic artery, which then gives rise to the common carotid and the right subclavian artery. You see those two vessels coming off there? Okay, then the second vessel off the aortic arch is going to be the left common carotid artery going up the neck. And then the third one, better go to the left arm because it's the left subclavian artery. And sure enough, it's going around there. Goes around there into the left arm. Okay, so again, look at this and understand this. This is the SVC with dense venous blood because of the left arm being injected. And the first thing you see coming off the aortic arch, you go up the ascending aorta, and you have the innominate, or the brachiocephalic artery, giving rise to the right subclavian and the right common carotid, and then the left common carotid artery comes off the aortic arch next. And then if you hang in a little longer and you go a little farther, you'll see that there is a subclavian artery that comes off the aortic arch. Okay, so that's the aortic arch, and you can see how on a chest radiograph the trachea is displaced a little bit to the right because the aortic arch crosses right alongside of the trachea on its left side. So on a chest radiograph, you usually see a little bit of a displacement, just as you see here. The trachea is displaced a little bit to the right because the aorta is on the left side of it. Okay, then what would this little angle here be? It's the carina, because this is the trachea, and you can see the little ringlets. You can kind of get an impression of those little dents all along the side from the ringlets, the cartilaginous rings of the trachea. And the trachea comes to this carina. This little point here is just called the carina, and we see the right main stem bronchus and the left main stem bronchus. Now, I'm not going to go through the pulmonary branch anatomy, but that's going to be important for you to understand. Let me ask you this. Here is a lucent line that looks like it's a gas-filled structure, and it's outside the airway. What would that be? This would be the esophagus. Okay, you often has a little bit of air in it, and sometimes you can see a lot of air in it, especially if there's a big hiatal hernia. All right, now let's look at something else here. Okay, aha, look at this big thing. Now, how do we miss this? What is this big monstrous structure here that's a contrast opacified structure? What is it? What that is is the left atrium. These are pulmonary veins coming from the lungs into the left atrium on the left side, and over here you see it coming, they're coming into the left atrium on the right side. And so this is the left atrium, and that means that it's going to have to communicate with the left ventricle, and that's what it does. So this is left atrium, and this is left ventricle. You see the thick wall of the left ventricle, the thick myocardium of the left ventricle, and they're the papillary muscles. And then as you go away from this connection to the left atrium, to the left ventricle, and you see the left ventricle goes to the aorta. Okay, and here's the SVC. And then where is this blood going? This is contrast-opacified blood in the SVC, and it doesn't seem to be going to the left atrium, is it? No, it's going to the right atrium because it's deoxygenated, and it needs to go from the right atrium to the right ventricle and then out the pulmonary artery like this and into the lungs to be reoxygenated. Kind of a little bit difficult to put together because it's not a nice schematic, but you guys hopefully have seen the schematic of how blood flows, and if you need that, or if you need a description of those basics, I'll be glad to present you one that you can understand, I think, pretty easily. Okay, so we have reviewed it in axial and coronal planes. Sagittal can be a little bit tricky. Let me see. Sagittal is usually good for problem solving, but not that good for getting an orientation. But here we're starting in the right side of the lung, and you have, therefore, this is a big pulmonary artery, I believe. Let's see if I can window that into the realm of visibility. Okay, so here's the this is the SVC, densely opacified by the blood that was contrast opacified in the left arm, as we saw before, going into the right atrium and right ventricle to get reoxygenated. This, however, is a pulmonary artery, and this pulmonary artery goes to the right like that, and then it goes to the left like this. So this is left pulmonary artery, main pulmonary artery, and then this is right pulmonary artery. So that is deoxygenated blood that's going to the lungs to be reoxygenated. And let's see what we have here in the lungs. Well, let's see, this is the right lung, and so you have major fissure, minor fissure, and you have the right upper lobe, right middle lobe, and right lower lobe. Okay, and then we cross over, and then we are back into the right main pulmonary artery, then you're into the main pulmonary artery, and then you go to the left main pulmonary artery. It kind of dives backward more. And then we follow this to the left side. And what do we have here? We have two lobes, left upper lobe, left lower lobe. This is the major fissure. There is no minor fissure, and there is no middle lobe on the left. So you have left upper lobe, left lower lobe, and this is where all the oxygenation takes place. And here you can see very nicely how the right ventricle gives rise to the right pulmonary outflow tract and then becomes the pulmonary artery, the main pulmonary artery, which then branches to the right and then branches to the left. Okay, and rising above that, but closely paralleling it because of that developmental shared history that the two have, where they were once part of one big artery, now they're two smaller arteries. You can see the aorta is closely positioned next to the main pulmonary artery. So you have the ascending aorta, you have the brachiocephalic artery coming off it first, then you have the left common carotid artery going up the neck. Oops, that was left subclavian. So here you have the brachiocephalic artery here, and then this is the left common carotid artery here going up into the neck, and this is the left subclavian artery going up into the supraclavicular area and out toward the arm. And this is also, again, a nice depiction of the thick myocardium that borders the left ventricle, and the right ventricle is in front of it, and the left ventricle is behind it. And here you have even the left atrium and its two tributaries from the lung of venous oxygenated blood coming from back from the lungs to go into the left side of the heart, initially the left atrium and then the left ventricle. I think I mistakenly commented that this was left ventricle, but it goes into the left atrium and then into the left ventricle, which is here with the big thick myocardium, and then it goes out the aorta, and that's right here. See how that comes from this chamber here. This is the left ventricle, thick myocardium, and then it gives rise to the aortic outflow tract, you could say. Here. It's here, not there. Here. So here's the left ventricle, and this is the left ventricular outflow tract, and it becomes the aorta. SVC. Esophagus. That's a nice view of the esophagus. Very nice. You see the air stripes in here, so you know this is the esophagus. Well, I hope that gives you a little bit better an orientation about what you've got when you're looking at the mediastinum. It all makes sense. These other little tiny things like this is probably a little lymph node. This is the arch of the azygous vein. We'll discuss that another time. So let me know if you have any questions.